Tom, you've done it again. And because of that, we're back in the medical anatomy bunker, and now we have to look at the wrist where he's experiencing pain and the lateral hand where he's experiencing pain as well. So let's work our way from superficial to deep in the hand and the wrist, and let's see what we find, and let's see whether we can investigate the possible anatomical causes of Tom's pain. So let's start superficially. So what's the differences between the palmar and the dorsal surfaces of the hand? Well, one is terminology, okay? And palmar in the hand can also be replaced with the synonymous term volar, okay? So you may hear the term volar instead of palmar with the hand. Differences: skin. Obviously the palmar skin is hairless. Vasculature. We won't go into this just yet, but there are some profound differences in the vasculature. Most of the arterial and venous structures that you'll find in the hand are going to be on the palmar side. And also muscle bulk. Now, on the dorsal side of the hand, there are very few muscles, whereas on the palmar side of the hand, there are significantly more, and this is represented by two eminences. So we have the thenar eminence, which is here, which is at the base of the thumb, and that's going to be all the thumb muscles. And we have the hypothenar eminence, which is the bulk of muscles here that are going to go onto our little finger. So here's the hypothenar eminence, and here's the thenar eminence. Some terminology before we begin. So the whole hand itself is sort of divided into the carpus, which is here, the metacarpus, which is here, and the digits, which are here. So what do they contain? Well, the carpus contains 8 carpal bones, and you can see some skin markings over the carpus itself, and you'll see that it marks flexures at the wrist. Now the metacarpals contain 5 metacarpal bones, and they're numbered, and in the hand they're numbered lateral to medial. Okay, so your thumb's number 1, 2, 3, 4, 5. Now the bones of the metacarpus can be palpated through the dorsal surface, but you're going to have a hard time indeed to get any reliable information about the state of the bone if you're palpating through the palmar or the volar surface. Digits. Number 1, this is referred to as the pollex. Number 2, this is referred to as the index. The third is the medius, and this forms the midline of the hand. Now this is important because when we're talking about abduction and adduction of digits, it is relative to this third digit, okay? So that means these digits here are currently abducted, okay? So we no longer talk about them moving laterally or moving medially, okay? If they're moving closer to the third digit, they are adducting. If they're moving farther away, being separated from the third digit, they are abducting, abducting. Right. Number 4 is the annulus. Number 5 is digitus minimus. Now, remember these terms because we're going to refer back to them when we look at the muscles, because some of the muscles take the terminology by which digits they either insert on or which digits they act on. Right, move on. So we're going to look at the carpus. So we've got 8 carpal bones, and they're divided up into proximal and distal rows, each with 4 carpals. Now they have a keystone arrangement. So what does a keystone actually mean? Well, a keystone is if you took a stonemason and you asked them to make an arch, then what would happen is that there would be a stone of an arch that would hold the whole thing together, and this is usually placed at the top, okay? So these middle stones here, these middle carpals, actually hold this whole wrist complex in place. Now it has a concavity on its anterior surface, and you can see that this is going to form, along with a ligament here called the flexor retinaculum, which we'll get to later. This is going to form a space called the carpal tunnel. So let's have a look at the carpal tunnel now. So this is roofed in by the flexor retinaculum. So we've got 4 points of attachment. We've got 2 lateral, one's going to be at the proximal and one's going to be at the distal row, and then we've got 2 medial, one's going to be at the proximal, one's going to be at the distal. So at the ends of each row. And then you can see in here we've got all these tendons of the long flexors, and these are going to have tendinous synovial sheaths around them. Now, this is a bit of an issue clinically because here we have a closed space and here we have structures that can potentially inflame. And of course what that means, and it's the same sort of concept as what we had in the brain, whenever you have swelling in the closed space, it can only mean one thing, and that's compression. And I feel really sorry for this poor bugger here. This is the median nerve that you can see here. And what will happen is that if you get swelling in this compartment, well, the median nerve, because we know that nerve structures are highly sensitive to mechanical compression, this is going to be the first victim. And it's going to be pushed against the flexor retinaculum, and this can cause classically known carpal tunnel syndrome. Right, so let's go back and look at the bones and the joints. So the proximal row, what joints do they contribute to? Well, they contribute to a radiocarpal joint here. So the scaphoid and the lunate make up a radiocarpal joint. But there is also an ulnar carpal joint, okay? Now, the important thing to understand about this is that this is not it's not a direct joint. So there's a direct articulation between the radius and the scaphoid and the lunate, but there is an indirect joint between the lunate here and the triquetrum. And why I say there's an indirect joint, it's because in between here there is an articular disc that is superimposed in between these two bones, which connects quite strongly to the ulnar styloid process. So you might see this as being referred to as an articular disc. You might see this as being referred to the meniscus. You might also see this being referred to as the triangular fibrocartilage complex. Now, I particularly liked the triangular fibrocartilage complex because it tells you what it is. It's triangular, it's made up of fibrocartilage, and it's complex. Brilliant. So you might see this joint referred to as the ulnocarpal joint, or you might see it referred to, and this is more so clinically, as the ulnar meniscal triquetral joint. Okay, cool. Now there's also a joint between the proximal and the distal carpal rows, and we refer to this as the mid-carpal joint. And lots of flexion and extension occurs at the mid-carpal joint, so it's important for us to have a solid articulation there. So proximal row of carpals, what do we have? Well, here we have the scaphoid, so we're starting laterally here, and then we have the lunate here. You can see them both articulating at the radiocarpal joint with the distal end of the radius. Here we have the triquetral joint, and that's going to articulate with the articular disc. Remember that's superimposed in here. And we have the piezoform. Okay? And the piezoform rests on the anterior surface of the triquetrum. I should point out that the triquetrum is also known, as I've put here, as the triquetral joint. Now, some of these bones of the proximal carpal row have strong, important attachments for the flexor retinaculum. Okay, so the attachments for that in the proximal carpal row are at the scaphoid tubercle or tuberosity, which is going to sit about here, and at the piezoform as well. Okay, we'll look at the distal connections of the flexor retinaculum shortly. Now, these anatomical names are named after the appearance of these carpal bones, and if we look at them, then we can kind of deduce. Now, if you look at the lunate from a lateral perspective, it really does look like a half moon. So I completely get that. And the triquetral bone, I look at it and I think, oh yeah, a wedge, okay, fair enough. I look at the piezoform and I think, oh yeah, it looks like a pea. But there's one that I just can't get my head around, and that's the scaphoid. Boat-shaped. Come on, boat-shaped, really. I just wonder what kind of mind-altering drugs these anatomists were smoking when they decided to name the scaphoid. Look, I could be wrong. So if anyone can see in the lab a boat within the scaphoid, please let me know. because I'd love to join the party. I'm just not quite there yet. Distal row. We start off, again, laterally with the trapezium here. Okay, and the trapezium is easily identified because it articulates with the digits of the thumb. So this is at the first carpo-metacarpal joint. Okay, so we have a saddle joint here. So that's why it's easy to identify. Trapezium. Now here we have the trapezoid. Okay, now it's really easy to get confused between the trapezium and the trapezoid. So the way I remember the trapezoid is that it's kind of trapped. I don't know if that helps you. Hopefully it does. Capitate. Now this is the largest carpal bone. And if you look at it, I sort of think, it's not very well depicted in this illustration, but if you look at it as an isolated carpal, I sort of think it looks like a babushka doll. And capitate was known as the sort of carpal that looks like a head. And it comes from the Latin called caput, which means head. Right. Hamate. Hamate you can see here. And hamate's really distinctive because it has a hook. So we have the hook of the hamate. Okay? And the hamate, the name hamate, comes from hamellus, which means hook in Latin. So we can see the distal carpal row attachments for the flexor retinaculum here. The trapezium has a little tubercle that we can see here. Okay, flexor retinaculum attaches there, and the hamate here has a hook, and that's going to be the final attachment of the flexor retinaculum. So let's have a closer look at the individual bones of the carpus. So the scaphoid here, the quote-unquote boat-shaped bone in the proximal carpal row, has a tubercle, which you can identify there. And this is really nice and palpable, this tubercle, also known as a tuberosity. And we can palpate this from the anterior side, and we will in the tutorial. Now, it's also got a prominent waist, which you can see here. So here's the waist here. Here would be the waist here. Okay, here'd be the waist along here. And it's vulnerable to breakage at the waist, coincidentally. And this is important clinically because a lot of the blood vessels of the scaphoid actually enter at the waist. And in lab, we're going to be talking about what potential serious sequelae can happen if we fracture the waist of the scaphoid and actually disrupt the blood vessels that enter into the waist. Okay? So when you're in tutorial later this week, make sure you can picture the scaphoid bone, where it sits, and that lovely little tubercle. There. Moving on. So the scaphoid is the most commonly fractured carpal bone. And over here you can see a PA wrist x-ray, and you can see this complete cortical interruption through the waist of the scaphoid. And over on the right image here, you can see that we've had a 3D CT reconstruction, and you can see that complete interruption within the waist of the scaphoid. Lunate. It's half moon shaped. Sorry, I don't know why that's disappearing on me there, but I'll talk you through it regardless. So if we look at it on a lateral surface, this is half moon shaped. Okay. Now, distally it articulates with the head of the capitate, and proximally it articulates at the radiocarpal joint. Okay, so with the distal end of the radius. Now, the lunate is the most commonly dislocated carpal bone. So I want to just draw your attention first to this image over on the right hand side here, and you can see that the hand, if we take a lateral wrist x-ray, that the third metacarpal of the hand forms a really stable column with the capitate bone here. Okay, so you can see the head, neck, body of the capitate, and then proximally with the lunate, and then proximally again with the radius. It's a really stable central column. And when we evaluate radiographs of a lateral wrist, we need to evaluate this column and the integrity of this column. Okay, so let's evaluate that on these. Let's start obviously on the lateral here first. So Here's the third metacarpal. Good, that looks good. Okay, I can see it has a nice articulation with the capitate there. Excellent. Okay, I can see the body, neck, head of the capitate, but I can't see a lunate here. So there's meant to be a lunate interposed between the capitate and the distal radius, but it's gone. Where's it gone? Ah, it's out here. That's not where it's supposed to be. So you can see that this lunate, which is meant to be here, has undergone a 90-degree rotation and moved in a volar or anterior or palmar direction. They're synonymous, okay? And you can see the lunate here, and hopefully you've got a good picture of what it should look like normally from your understanding about lateral wrist x-rays. Now on the PA view it's a little more difficult to detect, but you can still see it. So here's the lunate here, and you can see that it's overlapping with the capitate here. And the radiologists will call this the pi sign. I love that the radiologists have so many names after food. I just think it's wonderful. They're perpetually hungry in their little, darkened, absent of UV, rooms. And they call this the pi sign, okay, where the lunate overlies the capitate. So the lunate is the most commonly dislocated carpal bone. Let's move on. Triquetral or triquetrum bone. It's wedge-shaped and has the pisiform resting upon it. So here's the triquetral bone. Okay, pisiform you can see here resting upon it anteriorly, and we know that it's got an attachment for the flexor retinaculum. So there's the triquetrum or triquetral bone, and here's the pisiform itself, and you can see that on these two images here. Cool. Trapezium. Trapezium has a little tubercle here that faces toward the anterior or the palmar surface of the hand. It has an attachment for the flexor retinaculum. You can see on its lateral surface that we have sort of a little concave shape there. And we can see that the thumb, so the base of the first metacarpal, has a little convex shape there. And so this is termed a saddle joint. Now make sure you have a look for this little saddle joint in lab because it really does look like a saddle. Now the morphology of the saddle joint, the concavo-convexity of it, actually gives it its wide range of movement, which allows for the wide range of functional movements that we have at the thumb. Right, trapezoid. Okay, so we know that the trapezoid is trapped here at the carpus. Okay, it's the smallest in the distal row. The capitate is a larger carpal, as we mentioned before, has the head here, has the neck here, and the body here. Okay, I'll show you here. See, that's the head, that's the neck, and that's the body. And you think, why? Hang on a minute. Why does the body look smaller than the head? Well, it's only in this view. If you look at it from a lateral view, you'll see it has a very substantial body indeed. I sort of think that the capitate looks a little bit like a babushka doll. Maybe that's just me. Anyway, so the head is going to articulate with the lunate here. Okay, so just reviewing this, here's the trapezoid and here's the capitate. Now here's the hamate. The hamate has a hook which protrudes anteriorly, and we're going to actually palpate this as well. And so let's review the attachments of the flexor retinaculum before we go on. So it has an attachment at the hook of the hamate, which you can see the arrow pointing to here, has an attachment at the pisiform here, has an attachment at the tubercle of the scaphoid, and has an attachment at the tubercle of the trapezium here. Right, so some people have a little bit of difficulty in remembering the carpals, which is totally understandable. And the way I remember how to name and number the carpals is by going from lateral to medial and proximal to distal. I remember it by some lovers try positions that they can't handle. And good on them for doing so. Right, move on. Metacarpals. What do the metacarpals look like? Well, they're here, and they have a base, they have a head, and they have a shaft. So here's the base, here's the heads, oops, and here's the shafts down here. They're numbered 1 to 5. We've already discussed how they're actually numbered, and that's from lateral to medial. Now, number 1 you can see is much reduced, it's shorter, and you can also see that there's no direct articulation with the others, whereas you can see for the 2nd, 3rd, 4th and 5th, there's actually direct articulations in there. Now, there are little names for those joints, but I don't need you to know those for this unit. The phalanges. We've got 14 phalanges. How are they named? Well, here's the proximal phalanges, here's the middle phalanges, and here's the distal phalanges. Okay, and they're named again just like the metacarpals are. So this would be, for example, the 2nd proximal phalanx, okay? And this would be the 5th distal phalanx, right? Got it? Excellent. Now, you'll note that the pollex here, the thumb, only has 2, proximal and distal, so it doesn't have a middle phalanx. So what do the surfaces actually look like of the phalanges? Well, the dorsal is curved and the palmar is concave and flattened. And that's important because what happens, and we haven't got to this yet, is that the long flexor tendons are going to make their way and traverse across these flattened areas of the phalanges before inserting on either the middle or the distal phalanx. And so by having these kind of flat and concave volar surfaces, it means that the long flexor tendons are protected. So what do the surfaces look like? Well, the base of the proximal is concave, and you can see that here. So it has a little facet because it matches the head of the metacarpal, and the head of the metacarpal is rounded. Now the head of the proximal has little condyles, and that's matched with the base of the middle phalanx, which has 2 little facets here. And then the head of the middle has almost like a little trochlear appearance, like a little pulley, and then that matches the facet of the distal phalanx. Now the distal is quite easy to recognize as a bone because it has this little tuberosity, this little tuft on the end, and that's the radiological term for it, a distal tuft. Okay, T-U-F-T. Now the reason for this tuft or tuberosity is for the attachment of the nail bed and the digital pad, okay? And remember that there's always a risk whenever there's injury to the nail bed or the tuberosity for infection. This is an area really prone to infection, so keep that in mind. Right, this has been quite a long little mini lecture, so let's continue to explore what makes Tom tick and what he has potentially done to his wrist.